And now it is my honor to introduce Julia Maués, a phenomenal patient advocate who uses her voice and her advocacy to work with patients and researchers to make cancer research more patient-centered, innovative, and inclusive. We often have patients as panelists for our roundtable discussions, but this year we asked Julia to provide an opening keynote to share what it's been like to live with metastatic cancer during the global pandemic. Her comments will provide an important patient perspective to set the stage for discussions we will have on cancer care delivery and mental health for cancer survivors. So now I want you to take it away, Julia.
Thank you, Shelley. It's an honor to be here. So I'll talk a little bit about my own experience and try to provide a perspective as the patient voice, but I'll also talk about the problems with that. So this month, it has been 8 years from my cancer diagnosis. I was 29 and pregnant. I received some treatment during the pregnancy, but I couldn't do scans until I delivered my son, who, by the way, was strong, healthy, and full of hair while I was completely bald. When I got the results of the scans that I did after delivering him, I found out that my breast cancer had spread all throughout my bones, to my liver, and to my brain. So to say that my 30s have been quite different from what I had in mind is an understatement. So I have been through multiple surgeries. I've actually done a craniotomy to remove cancer from my brain. I think I've had close to 150 infusions of chemotherapy, probably about 50 or 60 sets of scans to check on the status of the cancer. And even with all this, I am one of the lucky ones. I am still counting up on my infusions, on my scans, and most importantly, on my years living with cancer. To stay alive, I go to the cancer center every 3 weeks. I get my blood counts checked. I see my doctor or nurse, and I get drugs that are keeping me alive, infused through a port that I have on my chest. I'm going to say this again. I need to take these drugs to stay alive. And I guess that qualifies as essential. So when the pandemic hit and we were told to stay home, apart from those who don't live with us, especially not indoors, what was I to do? And what were the millions of people living with cancer to do? There were a few very immediate changes. Most of them were actually quite problematic, like stopping clinical trials or postponing scans. There were some positive things, silver linings, like the widespread use of telehealth, and that has definitely been a huge positive. In my particular case, we extended the interval between my infusions from 3 to 4 weeks. We had to postpone a number of scans, and I saw my doctor a couple of times via telehealth. The drugs that I take, they are infusion, so that was a problem. And I remember trying to think, I don't know, like really out of the box. Can a nurse come to my house and give me my meds at home? Or instead of going to the hospital where COVID patients are also seen, can I go to a specific building treating cancer patients where I'm not exposed to COVID patients? And I talked to doctors, friends, people with cancer. I talked to leaders in the cancer space like Shelley. And a couple of things became very clear. The first is that people do not like change. Second, I realized that everyone is very different. So one of my friends, when I raised the idea of having home infusions, I said to her, what do you think of this? I think it would be maybe easier for us, and it's a way for us to get chemo. And she said, absolutely not. I do not want someone bringing their germs into my house. And I remember, oh, okay, well, I hadn't thought of that, but I think I'd rather have exposure to one person than to a whole hospital. But anyway, that was me, and that was her. So those were very different perspectives. And this is going to be probably the most important point that I'll make today. It's probably the most important point about people with cancer. There is no representative cancer patient. We are inherently different. Our experiences are different. Our cancers are different. Our lives before cancer are different. And the way that we deal with the cancer diagnosis is different. So there will not be a single solution for a problem. I believe that we need to be heard in numbers, and it needs to be from a diverse set of experience. So I'm here today speaking to you as a young woman. I'm a mom, and I'm living with metastatic cancer. It's a very unique perspective, and I know that it needs to be heard. But I don't know the experience of someone living in a small town hours away from a cancer center, or the experience of an elderly person already at an immensely high risk of death from COVID that is then also dealing with a cancer diagnosis. And I think most importantly, being white, I don't know the experience of a Black person living with cancer. Someone who, on top of cancer-related problems that I may be familiar with, also has to deal with systemic racism in our healthcare. And as Dr. King said, that is the most shocking and inhumane form of inequality. So for that reason, I urge you to listen to different patient experiences, and especially seek the voices experiencing the worst outcomes. So never have that one patient who you always call to get the patient perspective. Hear different people, hear many of us. I am just N equals 1. Each of us is just N equals 1. And I urge you to stay on today, listen to the other patients speaking at today's event, Patsy Hinton and Winora Johnson. And then when you go back to your work, make sure you bring in the patient perspective and seek different perspectives from patients. I think that same spirit of shared decision-making that we talk about all the time, and about the interaction with the patient and the doctor in the exam room, that needs to be brought over to policy and research. We want a seat at the table where the decisions are made. We want shared decision making at events like this one, because after all, our lives are the ones that are on the line. Thank you.
Thank you, Julia, for your really compelling comments. And I really appreciate you bringing up the point that all patients are different and have different needs. I remember when I reached out to you last spring to ask you, what do you, we're hearing about this home infusion, what do you think? And you thought, oh, that would be so helpful to me, because you would have to arrange for childcare for your son so that you could go to the cancer center. And then you asked some other people and you came back to me, you're like, oh, well, not everybody thinks that way. And you gave me some different views. And I think that's why it's so important to, like, as you said, to get multiple different perspectives. And especially, I think, thinking about the fact that you live as a white person with cancer and can't represent the experience of someone of a different race or ethnicity. Before we go to our panel, I would love you to say a couple of words about what we talked about before, about the kind of unique resilience that many cancer patients and survivors have that helped them during the pandemic, that maybe those of us who had never lived with a cancer diagnosis did not have.
Yeah, I thought I had a very unique experience where I have text chats with friends that are living with cancer, and I have text chats with moms at my son's school. And I remember when the pandemic hit and the school closed and things like that, the moms were freaking out. more than the cancer patients who really needed to figure out how to get the life-saving treatment that they are currently receiving. And I think that just shows how what we have faced as people living with cancer really prepared us to, like, all of a sudden, from one day to the next, your whole reality changed. And everything you thought your life was going to be before that is going to be different tomorrow. And yeah, we have lived that. And also we have lived with the fear for our lives. We have lived with fear of infection, you know, like a lot of us have gone through chemo, and that means your immune system's really weak. We've already worn masks in public spaces, or we've already had to be careful about who comes into our house and things like that. So that was something that really like jumped out at me as someone that like navigates different worlds. And I thought that was very unique because other people had never been exposed to a shock like that before.
Yeah. Thank you so much, Julia. And now I'd like to invite our first panel to join us. Julia is going to remain with us for the first panel, and she's joined by a distinguished group of cancer care professionals representing different disciplines and care settings to talk with us about the experimentation and changes in cancer care delivery that were born of necessity during the pandemic. We're going to talk about what of these changes should remain after the pandemic, and to what degree will these changes reduce or potentially exacerbate disparities in cancer access and outcomes. I'm honored to be joined by Dr. Melissa Dillmon of the Harbin Clinic Cancer Center in Rome, Georgia, Dr. Asmita Mishra of the Moffitt Cancer Center, Brenda Nevidjon, CEO of the Oncology Nursing Society, Dr. Deborah Schrag of the Dana-Farber Cancer Institute, and Dr. Karen Winkfield of the Meharry-Vanderbilt Alliance. So we're going to start with having each of our panelists provide some brief opening comments on your perspective and experiences with the change in cancer care during the pandemic and what will remain after the pandemic. So let's start with Dr. Dillmon.
Thank you, Shelley. It's an honor to be here today, and thank you, Julia, for your words. You know, we take care of patients every day, but it's great to sit and just hear and talk with patients outside of the patient setting. So it's great to hear your unique perspective. I am a medical oncologist in a multi-specialty group in Rome, Georgia. I see all types of cancer, other than children, see everything. I was asked last summer when we thought maybe COVID would have, be done by now, to help chair a task force, and Shelley and I were both on that task force through ASCO, really looking at when we emerge from this pandemic, whenever that is, what are the lessons we're going to learn? How is medicine going to be changed? And what can we ask for in the future to make sure that if there's another pandemic, and I think we all feel there might be one, how do we adjust and adapt and treat patients through that pandemic and not have those fears of where is my treatment going to happen and how? We never shut down our clinic. We thankfully, when we built our clinic about 5 years ago, had put individual bays in between each patient. So they were really separated off. So we didn't have to go to different hours. We didn't have to go to shutting down at all. We didn't do home infusion because, at least in my community, which is very rural, we barely have enough oncology certified nurses able to give infusions in our treatment centers and in our hospitals, but we just don't have that skill set out in the home health setting. So we continued on with our infusion therapy. But what I will say was shut down, and I think this is true across the country, was all of our screening capability, and our general surgeons were really, for a period of time, about 3 or 4 weeks, unable to do anything that wasn't an emergency surgery. So we knew that there were patients lying out there waiting whose cancers were progressing that we weren't getting into our office. And so that was a huge concern. So I don't know if anyone's gotten a chance to read it, but ASCO did publish a paper in December, and it really broke down, the task force did, 2 areas that have been impacted, clinical research as well as clinical care delivery. And really what we looked at on both of those task force was, how do we ensure equitable access to care? Obviously clinical trials were closed down and you couldn't travel to them, and people's already strained transportation issues became magnified. So how do we ensure that patients get the care that they need? And telehealth is one of those answers. At least we could be in contact visually with our patients, even if we weren't able to see them as often as we needed to. Then we really looked at how do we protect not only our patients, but also our workforce so that we can continue to work and provide that excellent care. And then really looking into policies that moving forward may help us continue to give excellent care or better care. So really looking at clinical trials, I thought this was fascinating, is how do we use telehealth to make clinical trials more accessible to those patients out in rural areas like mine. Thankfully, we have a research group across the state that's already set up, but a lot of rural areas can't get patients into clinical trials. But could the lessons that we learned from COVID allow us to push out clinical trials to the community? Can we do more of the lab draws and the visual assessments, et cetera, virtually so that patients are able to participate in these clinical trials that we really need to move the science forward? So I'll stop there. I could go on and on about what we've learned over the last year from COVID and are continuing to learn. But I wanted to share one picture. So, you said share your patient stories or get your patient story. This is one of my sweet patients. She was pregnant and diagnosed with breast cancer. And so we did her treatment during COVID and while she was pregnant, because she chose to continue to keep the baby. And so it was a struggle, but I mean, one of the greatest days of my life, even though I had to gown up in a moon suit to go visit her in the hospital when she had her baby boy, and she couldn't even have her husband in the hospital with her. But it was great to be there as her provider throughout that whole walk through COVID. So I kind of call this my COVID baby. I'm not an OBGYN, obviously, so I don't get to see many of these. But it was really exciting to see that success story, that despite all the struggles, she was able to get through. And this little baby story will be, uniquely special.
Thank you, Dr. Dillmon. Thank you so much for sharing that story. That was really great. Next, I'd like to have Dr. Mishra talk about her experience.
Hello, everyone, and thank you, Shelley, and thank you, Julia, for your very thoughtful and moving comments. It was very interesting for me to hear Dr. Dillmon's experience because she said right off of the bat that she comes from a rural community, and I'm from the Moffitt Cancer Center, which you can see behind me, which is a very large NCI designated cancer center in the Tampa Bay area. And many of the things that she experienced very much resonated with me as well. During our time acutely when the pandemic had started, I work in the blood and marrow transplantation and cellular immunotherapy department, which is a mouthful. So I will say BMT from now on from when talking about my department. But we see patients that are undergoing transplantations or receiving CAR T. So I was in a very unique position during COVID where my patients were designated as being critical. So I came into work every single day and we saw patients in person every single day during COVID, predominantly patients who had already undergone transplant, because those poor patients were already on the lurch. They had moved from their communities, wherever they were from across Florida, even internationally, to be within 5 to 10 miles of Moffitt to receive this treatment for a 3-month period. So when the pandemic struck, we were already in the midst of that. And so what our practice scaled down to was that those patients who were actively undergoing treatment, we saw them in person. And unfortunately, we have the very complex complication of chronic graft versus host disease, which is the donor cells attacking the patient body. So just from hearing that, I assume that many patients and providers can understand that that is something that cannot be treated in rural communities, cannot be treated by providers that don't know you, and quite frankly, can't be treated over Zoom. So those patients came in person too. We also continue to do transplants during that time. Because like I said, our patients don't have an option. These are emergent situations where people are in remission for a handful of weeks at times, and we have to go forward with transplant. And that was especially a unique time for us because getting cells from people, how do we do that? So we had European flights that were canceled or international flights in general that were canceled. So how are we getting donor cells from Germany now for my patients? And quite frankly, how am I getting them from Seattle? Because we were having domestic transportation problems as well. So we navigated that issue as well, and thankfully the National Marrow Donor Program has quite a lot of liaisons, including the government, that was able to assist with specialty charter flights from other countries, options that I didn't even know existed in this space, and to ensure that patients received the treatment that they needed, because we did not have the option of delaying people's care, and we were coordinating from multiple parts of the world. So it was a very interesting time for us. However, very similar to Julia's experience and many experience by Dr. Dillmon's patients and other patients as well, patients did have delays in their treatment. We had to be creative where best we could. So for example, autologous transplants were completely stopped throughout the country, as this was thought to be non-emergent, non-critical. And that was very difficult to tell our multiple myeloma and lymphoma patients, for example, that they had to wait, and that too indefinitely. We had no idea when we would be back open to do such procedures, and it was a very scary time. Additionally, the patients who did receive treatment came in alone. They came into clinic alone to hear the horrifying statistics I would present to them, and they had to make decisions in that space. And additionally, during their hospital stays, they were not allowed to have anyone with them at all, particularly early on. That has evolved. We now do allow some degree of visitation, albeit limited, and we have learned. I would say that we are not perfect, but we have learned. We have gotten creative. So we have made Zoom our ally. So prior, where patients would come in with, say, for example, a designated family member before COVID, now we can Zoom with a lot of their family members. So now we're able to get their children in the calls, whereas before we weren't able to navigate that issue. So we have multiple people, including military personnel overseas, who are able to jump onto a Zoom call on behalf of their family members. And so there have been some unique avenues and channels that I think we need to explore. But I would be remiss in talking about telehealth without considering demographics. And I would like to just take a few minutes to just talk about that. So we have conducted approximately 15,000 virtual visits since COVID began, and the average patient satisfaction is 95%. So that certainly speaks to not only the good digital experience, but also that the medical needs are addressed. And we need to certainly continue this as an avenue for taking care of our patients. But in regards to demographics specifically, 58% were female who had a telehealth visit, whereas 41% were male. But then more specifically talking about race and ethnicity, 78% were white, 5% were Black, with the remainder of the demographics being representative in single digits. And while this certainly represents our catchment area in the Tampa Bay region, I think that we cannot continue on our efforts in telehealth without thinking and considering very carefully about digital availability, literacy, and equity as we continue to work in this line. Thank you.
Thank you, Dr. Mishra. Now I'm going to turn it over to Brenda Nevidjon from the Oncology Nursing Society.
Thank you, Shelley. I'm very pleased to be a part of this wonderful panel and such a strong opening already. I think I'm going to ping off of what Dr. Mishra sort of ended with in terms of some of the digital divide that we experienced. And I'm not in the trenches, but I represent the almost 40,000 members that we have who are in the trenches and that we heard from very consistently. We have a platform that allows posting, and what we saw happen during this is an increase of activity because our nurses were sharing very, very frequently what was going on in their organizations and posing questions, some of them to us for guidance, some of them to each other about what the experience was. And certainly when it came to technology, there was the variation of patients that could or could not be reached using technology. But what the nurses were using the technology for was care coordination, obviously, management of symptoms that patients might be having, and education along the way. And to Dr. Mishra's comment, they were able to oftentimes with these have multiple people in on a Zoom, which was an advantage. It also is a challenge understanding who is in the room with the patient. The other benefit to technology goes to what we've heard already about the limits on visitation. And initially, anybody coming in, whether it was for an outpatient visit or for hospitalization, had no one be able to accompany them. And obviously that has eased, and there are now opportunities in most organizations for a single individual. But this is where FaceTime and Zoom became very important. We've seen the very poignant images of that on the news in the evening of people in the ICUs being ready to be intubated and having their last conversation, maybe forever or for a period of time, with family members. But this is very different than a phone call with a family member, and having that visual has been a positive. So there were some benefits, obviously, to various technologies during this time. I think that another area that Julia touched upon was this issue of treatment in the home. And so we did see, nurses did see changes in the site of care. Some of it was COVID related, obviously, in terms of where the testing sites were out in parking lots and different places to keep people away from the institution. But also some care began to be offered at the curb, if you will. And there is certainly a procedure, a process that was developed by a nurse at Hopkins to be able to give care at the curbside with the patient in the car and not having to leave the car. This is something that more people are inquiring about and understanding. What certainly contributed to this was that she was former military, had had field hospital experience, and she's one of our very innovative nurses as well, and looking for solutions for challenging situations. Then there was the movement of some care into the home that used to be in the organization. Some of that was accomplished by converting patients to oral agents and not having them coming in for infused agents. And some of it was, in some settings, bringing the infusion into the home. Home health nurses have done all sorts of treatments in the home for patients before. And in fact, in certain protocols, there are chemotherapies that are administered through ambulatory pumps. Thus, the patient is in the home and in the community with those pumps. But some of what was being discussed was protocols that we don't typically think of being given in the home, and agents that we don't typically think of being in the home. And as Julia said, some patients were absolutely not going to want this because of the concern of during COVID of germs coming into the home, and others liked the idea. And some of the payers were encouraging this, as I think my physician colleagues probably are well aware. So we had a lot of query about that to our organization. And so what we ended up doing to support nurses out in practice, we began to look at our standards of practice, our protocol around certain kinds of practices. And we did make some recommendations of, during a pandemic, what kinds of things need to perhaps be modified for a time being. And that included some of the safety precautions with the personal protective equipment when there are shortages in the hospital and they're wanting only the certain units to get those supplies. Well, how does an oncology nurse also fall in line to get some of those supplies? When it came to infusions in the home, we have published very clearly that if organizations are going to be, particularly home health or medical care organizations administering in the home, there are certain things that need to be in place and have outlined that very clearly. So those are some of the things that if they continue will have implications, particularly if there is a movement from the payer environment to encourage or reimburse for home infusion, home administration. There are many complicated things that need to be in place for safety reasons. Another area that I want to touch upon, though, is the impact of this last year plus on the workforce. We know that there were many decisions that had to be made early on. We know that nurses were furloughed, oncology nurses were furloughed. If you think about nurse navigators who were engaged in the screening end of the cancer trajectory, many of those nurses were furloughed, because what organizations sometimes forget is a nurse is not a nurse is not a nurse. And the specialization in nursing, you take somebody who is a navigator and working with individuals for cancer screening, it doesn't mean you can take that person and move them immediately into an ICU caring for an intubated COVID patient. And so we saw furloughs. We did hear of some layoffs of nurses at a time when the demand for nurses in these critical care areas was quite high. And we also know the impact of helping people coming in for cancer treatment wherever they were in their treatment trajectory and saying, no, you can't bring your spouse with you, or your child, your daughter, your adult daughter, your adult son with you, and then reassuring them that their family member would be well taken care of, created additional stress in the situation. So what we're facing right now in terms of specifically the nursing workforce, but I think my physician colleagues may have knowledge in terms of the physician workforce, is nurses are beginning to leave the profession. They're beginning to leave their jobs, and some leaving the profession. And I anticipate that when the pandemic is over, if there becomes that day when it's truly over, not only in the US, but globally, I think we're going to see even a strongly augmented shortage, a high demand, and yet a weakened supply. And we will also see the toll of the experience that people have had. Now, Julia made an interesting comment about the text groups that she was in and the resilience of the patient group, her colleagues with a cancer diagnosis. I do think that oncology nurses probably have more resilience because of the specialty that we have, the care and relationship with patients, with the interprofessional team. But we are seeing the wear and tear on our members as well. So I think that'll be a post-pandemic concern. And I think potentially, in the rural areas, listening to Dr. Dillon, it could even be more of a challenge. So I think I'll stop there. Thank you.
Hi there. I had a little technical difficulty and I didn't hear everything you said, Brenda. I'm sorry, but I'm back now, and I would like to introduce Dr. Schrag to make her next comment. If I ask you a question you've already answered, forgive me because I didn't hear everything you said, but at least I'll hear from now on. So now I'll turn it over to Dr. Schrag.
Hi, it's nice to be with everyone. Thank you so much to Shelley for holding this session, and I'm going to try to expand on what my colleagues who are healthcare professionals have said, as well as Julia's really important remarks at the beginning. So I'm a medical oncologist at Dana-Farber Cancer Institute, which is a tertiary care institution in Boston, Massachusetts. So we're an urban area, although we have we draw patients from really across New England. So the first thing I want to say is the phenomenon that Julia mentioned at the beginning. And she spoke about how, as a cancer patient, she's used to her world being upended and things being different and being nimble and being prepared for the unexpected, and has really, over the past 8 years, as we heard so poignantly, tapped into this inner strength and resiliency. And I think for many, many people, the pandemic was an introduction to the reality that cancer patients live every day. So in some horribly perverse way, cancer patients already had some kind of a special, particularly people who've been living with cancer or advanced cancer for a long period of time, not referring to people who are newly diagnosed, for whom this was definitely a double whammy, but people living with cancer for a long period of time already have this inner reserve and well of resilience. And we found that many were able to marshal that during the pandemic. I had so many patients come in and describe how they were counseling other people with far less serious health concerns during the pandemic, even individuals who were coping with the COVID virus itself. And this phenomenon just kept coming up again and again. And we've labeled it. I think everyone's heard of the term PTSD, for post-traumatic stress disorder. But the term that we like to use is post-traumatic stress power, PTSP. Some people also label it PTSP for purpose, which is after a cancer diagnosis, so many patients describe a kind of a heightened sense of feeling empowered. And that includes things like being able to self-advocate for what their needs are, whether it's being able to ask friends and family to help out, whether it's being able to really focus on creating purpose and meaning in life. And one of the good things that the pandemic brought was that some of these core skills our cancer patients were really able to leverage and tap into to help get through this extraordinarily difficult time. So we also remained open throughout the pandemic, and what we cut back on was primarily cancer screening and less sort of acute needs, but we continued to give chemotherapy to our patients the entire time. And as clinicians, we were on site every day and weekends and extra call and backup coverage. And we had these very intimate encounters because we were so pared down. So we had a skeletal crew of staff. Many of our administrative support staff were not there. We had a lot more intimacy doing things like vital signs ourselves, doing more check-in as physicians. Things were slower. Clinic visits were fewer and farther between, but we were a lot more hands-on. And I think one of the paradoxical silver linings was this opportunity to really connect with some of our core values in medicine relating to healing and talking to people about fears and anxiety, and just that opportunity to slow down and focus on the fact that there's a human being right in front of us was really valuable. Clinic felt, in an insane way, it felt a little bit less chaotic. I also think that there was something important about how the playing field was leveled, because as clinicians, we too were frightened. We were faced with this uncertain virus and we were donning all kinds of uncomfortable paper materials. And I remember being in clinic one day and being near tears because between these reading glasses that are always on my head and the face shield that they were making me wear and breathing, everything was fogged up and I just couldn't couldn't write orders and make it all work. And I had to ditch the face shield to be able to get through my clinic day. And I think there was a lot of empathy that was shared between patients and physicians. And I hope that as we emerge from the pandemic, some of that remains, because I think it really allowed us all to tap into what we value, which is our role as healers and helping our patients tap into their power and their sense of purpose. So now for some of the challenges. I would say that during the pandemic, we've had multiple challenges. I think the economic crises of many, many people losing their jobs and facing financial uncertainty. We saw how that had adverse impacts on cancer care again and again and again. And I also think the nation's increasing recognition of structural racism and mass shootings and deaths from police brutality, which happened again and again and again, was really, really important. It's tragic, but I think the stress, particularly on our communities of color, was immense. And it was COVID and being hit harder by COVID, and also just being demoralized and devastated by having to contend with sort of police brutality and who's really here to protect us and who's on our side. And that there was just a lot of grieving going on, and lots of trust issues coming to the fore. And I think that took and will continue to take a lot of our attention. And it's important for us to attend to that as healers. It's not something that any of us can ignore. And there are no easy, simple solutions. I think there was a lot of relief yesterday at the verdict, the important verdict in Minneapolis, but I think that's coinciding. It's another pandemic of sorts, which made everything more complicated. Specifically with respect to care delivery, there are some other silver linings that we're really excited about. And a lot of those have to do with remote consenting for clinical trials. So our previous standard operating procedure was to have patients come into clinic, meet with a research nurse, and consent to studies in a face-to-face visit, essentially because of what I would call antiquated policies requiring a so-called wet signature, which is a fresh written signature. But this often meant that patients did not have adequate time to think through a consent form, read it, make sure it's something that they wanted to do. Some people might feel pressured, or some people, in the interest of time and clinic workflow, might simply not present the clinical trial. So what we've been able to re-engineer our system to do right now is to identify who might be eligible for clinical trials, share consent forms and options in advance, and have research staff educate patients and work with them and answer questions by Zoom, because those folks are not necessarily back in clinic, so that by the time people make it to clinic, they've had all those encounters. People come informed, educated with questions, and they feel better prepared. It's less stressed and less rushed. And I hope, we intend not to go back to that in the future. I think that has the potential to increase the number of patients participating in trials. I think it has the potential to increase the diversity of the kinds of participants who go in clinical trials. I think it has the potential to improve clinic efficiency and the quality of care, and how informed and empowered patients feel about participating in research. I don't think telehealth is the answer. We've made it work where we've had to. The digital divide concerns are very real. I think telehealth needs to stay, but it's not a panacea, and it's not appropriate in all circumstances. One thing I think we have to really guard against is there has been some proliferation of multiple Zoom telehealth visits, or some patients who are getting 3 and 4 opinions, because it's relatively easy to do that by telehealth. And I do think that can cause a lot of confusion and chaos and some anxiety. So telehealth second opinions are important, but they think that they need to be used appropriately. And I think we need to achieve the right balance in that regard. So again, lots of stresses and strains and a very difficult time. But I think that some of the adaptations that we made during the pandemic will be here to stay and will help us improve the quality of care, the efficiency of care, the effectiveness of care, and even the patient-centeredness of care. I think during the past year, we've had so many patients enroll in our patient portal, and we've opened up notes and electronic health records. So more patients are on the portal. Patients are reading their own notes. They're asking us questions. They're holding clinicians' feet to the fire. Patients are getting more and more empowered. And I believe that that's good for us all. So I'll stop there.
Thank you very much, Dr. Schrag. I love that term, post-traumatic stress power. That's amazing. So next and finally, and last but not least, Dr. Winkfield.
Thank you so much, Shelley. And I am so honored to be on this panel with all of these amazing women. It's been great. So thank you all for your fabulous comments. Julia, thank you for sharing your personal story. And I think Dr. Schrag just mentioned, this whole thing of patient-centeredness really coming to the fore because of COVID. Look, I think I'm the sole radiation oncologist on this panel. I treat primarily hematologic malignancies, so lymphoma, leukemia, multiple myeloma, bone marrow transplant, but I also treat breast cancer, which, as you know, is very common. And, for women with breast cancer who have gone through breast cancer radiation therapy, back in the day, and I'm talking about pre-COVID, we would talk about 6 weeks worth of therapy. And what's been fascinating to see is how we've been able to shorten and condense time, not only in terms of time that patients have to be on the treatment table, but also time in terms of length of treatment courses. And we're doing it based off of data. It's not like we've been doing this in a data-free zone. There's been lots of data that talks about what we call in radiation therapy, hypofractionation, or giving slightly higher doses of radiation therapy each day with the intent of actually shortening the radiation therapy course. And that's been one of the things that's been fascinating to me, to see how quickly we could actually move to that. Similar to the way that people talk about telemedicine and telehealth. We couldn't do it for the life of us. We couldn't get insurance companies to pay for it, but amazing what happens with COVID, how we were able to make it happen. Same thing with moving towards hypofractionation. And one of the things that it reminds me of is this whole moniker. We talk all the time about precision medicine, the right treatment for the right patient at the right time. And that includes all facets of therapy, not just targeted agents or looking for specific genetic abnormalities, but it's saying, who is the person who's sitting in front of me? And I do think that COVID has enabled all of us as providers, practitioners, people who are sitting at the front desk of cancer centers to really start to look not just at what's happening in the clinic, but look really at the person who's sitting in front of us. Dr. Schrag also mentioned this issue of really understanding the structural racism that's been built into the system. George Floyd's death was not the first death of a Black man, but it's certainly one where we literally saw it happening in front of our eyes, where it's been recorded. And not that that was the only video that's ever been produced, but COVID caused a stillness for every single person in the United States, and indeed the world, where we were almost captive audience to sit there and watch for 8+ minutes while the life of a Black man got snuffed out. And again, as a Black woman and someone who has been in the trenches around health equity and the reduction of cancer disparities that disproportionately impact Blacks in this country, while I'm very thrilled to see that there's been this increased attention to the issues related to race and ethnicity in this country, there's so much more work to do. I'm grateful that people have started to ask the questions, that they're not afraid to ask the questions as much as perhaps they were in the past. It's okay to talk about race. We have to talk about race. We have to talk about structural injustices, just the same way we have to talk about that patient who's sitting in front of us. Who are they? What's their social context? What are their social determinants of health? What insurance do they have? Or what insurance do they not have? Financial toxicity has plagued cancer patients for decades. It's the #1 cause of medical bankruptcy in this country. And so, yes, I'm very pleased that because of COVID, people are asking these questions, but we see the challenges that exist in our healthcare system. The fact that insurance, healthcare insurance is tied to employment. Well, what about the millions of Americans who lost their job and therefore lost their health insurance? It impacted cancer care along the continuum, from prevention to screening and even access to treatment. Again, as a radiation oncologist, one of the things that we did do is take a look at our patient panels. Are there any patients for whom we could delay therapy, right? While we were trying to figure out this COVID thing, making sure that we reduced the number of patients that were coming through the doors. We oftentimes delayed patients with prostate cancer. We couldn't do that for patients with head and neck cancer, knowing that there's an acuity to making sure these patients got treated. But we've certainly delayed sometimes our breast cancer patients for their start of therapy. And as I've already mentioned, this treatment courses got shorter. So there's good and there was bad. So my hope is that this whole COVID thing has really enabled us as providers, as institutions, to say what's best for the patient. And we certainly saw this with clinical trials, as was already mentioned, the fact that we're now able to consent remotely. But also, as a clinical trialist myself, there are so many times where you have a study or a lab draw and you just kind of toss it in there, right? What does it matter? Well, it matters because it matters to the patient. And we've even had to adjust the way clinical trials are done to say, do we really need that extra CT scan? Do we really need that extra blood draw? Or can we do it perhaps maybe getting the blood draw closer to the patient's home and having the results sent in versus dragging the person in, 20 miles, or even if they're 10 miles away but have to take public transportation? Is there a way for us to put the patient first? And so, I think there's been some wonderful things that have come out of COVID. Again, this mindfulness, this patient-centeredness, the thinking of, is there a way that we can really make sure that what we are doing is absolutely needed? And it's enabled providers to really learn how to ask those tough questions of patients. Do you have food at home? Food insecurity, a major issue with cancer patients to begin with, and now with COVID, it's been exacerbated. So my hope is that we all can put on our advocate's hat, not just Julia, who has been a staunch advocate for patients who've had metastatic breast cancer and for other patients who are living with cancer, but really that we can advocate on behalf of our healthcare system. How can we make sure that we don't just throw away the stuff that we've learned from COVID, that we really do the deep work when it comes to how do we think about structural racism? What are the things that I can do personally to help overcome some of those things? What are the things that I can do as a clinical trialist to make sure the study is focused on patients? That includes including them before the study has been created, right? Community engagement, engaging that community beforehand. And again, each and every single one of us saying, what is it that I can do to help support those advocacy groups, many of whom who are stalwart there, American Cancer Society, who used to provide transportation for our patients coming in and out for radiation that unfortunately had to condense some of those services. How can we help support those organizations that have spent decades supporting our cancer centers and our cancer patients? These are the things that I hope we can continue to do moving forward post-COVID, and really kind of thinking about putting the patients first.
Thank you. Wow. You all are amazing. That was really, each one of you had some incredibly important comments to make. So I'd like to bring everyone, Zach will bring everybody up on the screen so we can, we don't have a ton of time for discussion, but I have so many questions running through my mind right now. But one of the things, I want to start with this. So you talked about how, COVID obviously just blew open everything and gave us the chance to accelerate innovations that maybe had so many roadblocks in place before, and now those roadblocks have been removed. And I loved what Dr. Schrag said about being able to focus on healing, and what you said, Dr. Winkfield, about the patient in front of you. And we know that all patients are different, but we also know you all as cancer care providers are stressed in terms of how many patients you have to see, in terms of, the financial aspects of delivering cancer care, in terms of the need for cancer care. So workflow is always king. I mean, we every time we talk about anything, quality measurement or best practices, it's always about workflow. How do we make sure that when we come out of this pandemic, that we can continue that focus on the patient in front of you, even as you're dealing with all of the other challenges of the workflow and the demand for your services and your time, to make sure, because as Julia so eloquently said, every patient is different and needs different things from you. And maybe the pandemic let you focus on that. How do we make sure that continues so that we really are delivering personalized patient-centered care? I don't know who wants to start, but that's my big question. Anyone?
Shelley, I'm never going to be shy about talking, so I'm going to keep this brief because I saw that Dr. Mishra also had a thought. But here's the deal. Some of this, again, goes back to advocacy. Part of the challenge oftentimes pre-COVID was that we oftentimes as providers didn't have time to do a lot of that deep work that we wanted to do. And so this is where advocacy, even at the institutional level, can be helpful. What supports are there for providers? I actually when I was at Wake Forest, I was the Associate Director for Community Outreach and Engagement at the Wake Forest Comprehensive Cancer Center. And I implemented a population health navigation program because frankly, our clinicians were oftentimes bogged down in the details of clinical care, making sure patients had what they needed to get the treatment that they needed, that they couldn't oftentimes ask the appropriate questions when it came to those social determinants of health. And so the population health navigation program was implemented to help support the patients along that journey, to ask those questions. So my hope is that while, yes, we've had a little bit of time to relax, quote unquote, as providers, and maybe have a little bit more time to ask those questions, I think we've oftentimes seen our patients sitting in front of them, but we were afraid to ask the questions that we wanted to ask because we didn't know what the resources were that were available, right? Why are you going to ask somebody about transportation and not know how to get that for them, right? So that's where the partnerships come in. That's why providing navigational services come in, social work, other supports, making sure you're engaging the community. Those community-based organizations can really be helpful. And so now's the time, before we start to open things back up, to really strategize around who are our partners and who can we employ, who can we utilize to make sure our patient's journey is one where we can actually help them feel that they are the most important person in the room at that time, because they are.
Great, thank you. Dr. Mishra, you had something you wanted to say?
I feel like Dr. Winkfield took the words right out of my mouth so eloquently. But very specifically talking about telehealth, I think she brought up a very important point, which is the navigation piece, identifying who is this suitable for. So, there have been many different challenges. We found insurance providers have been certainly an issue, and this was also brought up by Brenda, who are our partners out there that will allow us to have these resources for our patients, and how do we make sure that those partners understand that this is something that not only the patients want, desire, benefit from, but us as providers want, desire, and for them as well, and want to have flexibility in the way that we are able to treat them. Given that we have patients who are coming from rural communities or communities that have less resources, how do we reach out to them, and what sort of resources do we have for them? And so certainly the payers are a major contributor here to what we can actually offer to the patients. And so certainly that is somewhere that we will have to continue to work. And then in regards to navigation, I think that the tough questions are tough for a reason. And Dr. Winkfield was very astute to bring that up. And oftentimes providers either are unaware, do not have the sensitivity regarding asking those questions, are time constrained regarding that. And so the navigation services are very important because it gives the patients some separation from their provider, where they are able to confidentially tell the navigation team what their resources are, what their availability is for their options, and they can navigate around that. So many times patients do not want to let their physicians know that they are having food insecurity, digital illiteracy, and so certainly navigation services can help us with that.
I want to just kind of chime in. I mean, I'm blessed in that years back, we chose to be part of an OCN OCM program. And so, we are getting some federal help, although it doesn't pay for the program at all, as far as a social worker. But, speaking for my community oncology colleagues, there's no free time. There's no days of research. There's no resident underneath you or fellow underneath you. And so it is you on the front lines all day, every day. And and like I said, nothing ever really slowed down for us. And right now I'm busier than I've ever been. So I think that emphasizing to the community physicians, the people out there in the trenches, seeing 25 patients a day, every day, 5 days a week or more, I think emphasizing to them what navigation does, how that makes it different is important. Again, rural area, we tapped into our farmers because I had farmers come in saying, I've got milk sitting on the shelf that's going to spoil. What can we do? And it was that story over and over, all the food that was going to waste because no one could transport it. So we said, bring it into our navigating services, which are up on the 3rd floor. And we put together food boxes, and we tapped into, because our social worker knows all the people who are struggling, because she knows them personally, because she sees every single one during education day. So we had 175 boxes go out every week. That was enough to feed a family, and so I think that was, it gave the farmers some sense of purpose. But your average cancer center out in a rural community may not have all those resources, but it's really about being creative when tragedy comes your way. And like Julia said, with this post-traumatic stress power, I agree with that completely. And I think that the physicians and the nurses that have lived through COVID have a different type of stress power that hopefully has come to us, and will use the creativity that allowed us to survive during this to make those strides to move forward. But I think that realizing the additional stresses out in the areas that never had those resources, and then now are even more desperate, I think that's really about getting the word out to them about the importance of navigation and social workers and community involvement. It's huge.
A concern that I have is that at some point the dust will settle and the financial impact on our health systems is going to be realized. And while we know the benefits of the things we're talking about and why they are important to have in our cancer programs, I do fear that at some point in our organizations, there will be tough decisions in terms of do we invest in A or do we invest in B? And if we don't invest in B, what happens? And that's where I want to go back to something Dr. Winkfield said. It's the internal to the system advocacy that's going to be so important. And the data that we know that we have with our patients, to be able to not just share data, but tell the story, like that story of your farmers who had food and what you could do with that and how that benefited. That's always very influential on the Hill with politicians. I think it will be with healthcare executives as well when they're having to make some tough decisions. But I think we're going to see some of that happen, not necessarily this year, although it may happen as organizations go into budgeting, depending on what budget cycle they're on. Because I am hearing from nurses that there are some tough decisions being made in organizations.
So, okay.
So this is Deb. I have just a story. It just coincidentally turns out that I have a story about a dairy farmer also, but it's slightly different. So in Boston, we are sort of the city that provides specialty care for Maine, which is a rural state. And some time ago, not too long ago, back in the fall, I had a dairy farmer from Maine drive down to consider clinical trials. Now, this is somebody who is already driving 2 hours to receive their routine cancer care in the city of Portland, Maine, which is about 2 hours north of Boston. And this farmer came down for clinical trial options. And it was late in the afternoon and I was already running 45 minutes behind. And I could tell that this gentleman was just getting really anxious and he just looked like he wanted to be somewhere else. Very stoic, Northern New England, man of few words. Basically, he had to get home to milk the cows. because he runs a dairy farm, and he just could not process or hear anything I had to say about clinical trial options. Now, here's the truth. He had driven 5.5 hours because his oncologist, well-intentioned in Portland, Maine, thought he needed a consult, and so did his relatives. That consultation could have happened over telehealth in the pandemic or post-pandemic. It would have been far more efficient for me to have an initial conversation with him by Zoom, even in his rural area. He actually did have connectivity. I later went on to have a conversation with him, and we could keep in touch that way and have him drive down selectively when we identified the right clinical trial. He could get the information, read about it, consent. And I hope that what we've learned in the pandemic does support individuals in rural areas, and that we are better able to respect patients' time. I think there's a real value proposition there for everyone. And I think there's the opportunity to improve health equity and quality and efficiency and also value. I do think that we have to advocate for the healthcare payers about how these new ways of communicating and delivering care add value. And that's really on us. Shelley, your organization is so pivotal and key in that advocacy work, but as clinicians, the clinical community needs to do it as well. With respect to navigation, I think we can think of navigation as a set of professionals, or we can think of it as a concept. Not every community is able, or health system is able to employ specific navigators, but every health system and in community is able to incorporate and embed the concept of navigation. So you may not be able to hire navigators per se, but the concept that people need help navigating the incredible complexity, I think, is a scalable concept. And we just have to figure out how to do that so that we don't lose people, so people don't fall between the cracks, and that everyone is able to get the best possible care that they can.
Thank you, Dr. Schrag. I have so many questions, but we don't have very much time. I do want to, first of all, I want to say, ask Julia if you want to comment, and then I have one more question I would like to pose.
So another thing that I didn't mention in my remarks, and I felt that was important, and Shelley, we talked about it, was the impact on people that had their life and during the pandemic due to cancer and their families. So I have obviously with metastatic cancer, am connected with a number of people that are nearing the end of their lives. And I have many friends that died and their families had to experience the end of their life without seeing them or without mourning them. And that was a huge problem, I think, for our community of people living with metastatic cancer, and for people, I think, that died for various other reasons, including COVID, but obviously people were still dying for other reasons, and that was very, very difficult for our community, I think.
Thank you for pointing that out, Julia. That's, I think, a really important point. And we didn't, I mean, I think collectively as a country, we didn't have the opportunity to grieve people that we've lost, whether to COVID or to cancer. You know, that I lost an uncle to cancer last summer, and we haven't had any kind of celebration or memorial for him, but we're going to do that in May around the time that would be his birthday. So, but we, you know, it's a year later almost. So I think people have to find their own ways to get that kind of closure or you know, remembering the person that they lost. But I think we're all dealing with that, but especially I think when you lose people to cancer. I know that people have to leave, but I would love to, if you could, we talked about disparities in outcomes and health equity and systemic racism. What's one thing that makes you hopeful about our ability to address this better going forward that COVID has brought to light, and the racial justice issues? Is there something that makes you optimistic and something that we need to keep doing or start doing to try to better address health equity and reduce disparities.
Well, Shelley, let me just say that I think one of the things that, again, I think I'm hopeful about is that more people's eyes are open and that they are willing to start a conversation. There is a lot of personal work that needs to be done first, though. Like, I don't need people just coming in saying, well, how do we do this, right? My colleagues and I got together and wrote a paper on social justice in radiation oncology. Actually, the tools that are in there, the resources that are in there, we were very intentional about understanding what microaggressions are, right? We saw the big macroaggressions of watching Black people die or get shot or whatever, but there are microaggressions that happen every single day that are part of the systemic racism. And I would encourage people to look up that paper that was actually published in the International Journal of Radiation Oncology, Biology, and Physics, because it actually does have literally clear steps on what you can do personally to help start to think about ways to address racial inequities, and then at the institutional level. So those are the leads and the ATIP kind of principles, and I would encourage people to take a look at that.
Thank you, Dr. Winkfield. We'll look for that and add it to the background materials for this session to our website. And does anyone else have a comment they'd like to make on that question? Yeah, Julia.
I'll just say that I think in general, people, especially white people, have started to realize that they all need to be doing something, right? And even if it's something small or the small space that you occupy, it is on you to start taking actions to end systemic racism. And I can speak for myself, and I know a number of advocates in cancer are focusing on what their role as white advocates are, and when do we need to shine a light on the stories of Black patients and bring their perspectives into advocacy.
I think the other thing, Shelley, is we have an administration that is dealing with a multitude of irons in the fire, but it is an administration that understands cancer and understands the issues around healthcare equity in the country. And so when we think of advocacy in the formal sense, in terms of policymakers, I think that we have an opportunity in terms of the Biden administration, but we also have a fractured Congress. And something that was learned in the pandemic is the importance of voting. And I think that this is another area that as advocates in the cancer space, we need to be thinking of our advocacy even in the larger space and what's happening in our states around potential laws that'll suppress voting, which will be important in the bigger picture of policy setting.
Thank you, Brenda. I love it when people bring it back to policy and politics too, because that's of course a lot of what we do at NCCS. I could go on, but I know some of you have hard stops because you are busy physicians in clinic and have to get back to your patients. So I want to thank you all so much for joining us. I'm very sorry we didn't get to all the questions. I know we could have continued this conversation longer, but I am grateful to all of you for being with us today and taking time out of your schedules and for the wonderful discussion that we had. I'd like us to take a 5-minute break before we start our next panel, because I'm sure people need to refresh their coffee and have bio breaks. So we will be back in 5 minutes with our next panel on mental health and cancer survivors. Thank you all again for joining us.